Thank you, sir. Thanks to Hetero team and Dr. Prashant. It's a great honor to have a Dr. Pramod Jog sir with us. Dr. Jog has been mentor to many of the pediatrician, and I'm one of them, sir. I do remember all your lectures, all your mnemonics, and all your uh, input in the lectures. I remember one very good thing which you have been describing in the lecture, that the charges which you take from the patient should be decided by the mother wearing a Mangal Sutra. If the Mangal Sutra is only a black dhaga, then that means she is very poor. You can leave them without charging. If Mangal Sutra has a three chain, that means she is millionaire family. So this was the best thing which I still remember. Probably in one of the Pedicon 15, 20 years back, you had described it in your talk, sir. So we are really honored. Dr. Ravi, good to see you again with a talk on influenza. Dr. Ravi has been a very good academician and a very powerful man in the practice also. So we just go over to the presentation. The whole idea of the talk is what is a role of Oseltamivir in flu management. As we discussed, Dr. Jog would be the moderator of the session. The content would be healthcare challenges in the monsoon and their diagnosis, influenza and its complications, clinical evidence of oseltamivir, and guideline recommendation for empirical use of the drug. Healthcare related issues in monsoon are influenza like illness, H1N1, severe acute respiratory illness, and COVID-19. We all know about these issues. COVID, we all have faced, and the same presentation can come in the influenza disease. In India, we know that influenza do exist. The seasonal variability is always there. The usual peak is between February, March, and in the August, September. Correct time to vaccinate probably in the southern part, maybe May, June, and even in the January, February, it is the best to vaccinate the child. These are the data which has been taken from the Purple Book of Vaccination from the Indian Academy of Pediatrics. It clearly shows that the peak of influenza comes in February, March, and in the July, August, and September. The same thing we are facing nowadays. Good number of influenza-like illness cases are coming. These are the statistical figures which has been in the Purple Book of the Pediatric IAP, mentioning the number of death, number of hospitalization, number of respiratory infection, etc. Again, the year-wise distribution of influenza illness, as we all know, and we had seen that the epidemic was very high in 2019. We had a good number of cases, 28,000 cases, and in 22, 12,000 cases till March 22. So these are the data indicating that influenza does exist, and it creates a lot of trouble to the pediatric and to the adult patient. These are the Indian data. 5 to 10% of all ARI are due to influenza. 10 children out of 100 suffer from influenza, and influenza associated respiratory tract infections are 33 to 44 per 1,000 children. Northern India, the peak is usually in the January, March. Central India, it is in the July to September. And Southern India, it is September to November. So practically speaking, all throughout the year, India would have influenza disease. Winter and monsoon, there is a peak. And the pattern of circulating strain varies from the part and from season to season. This is an overview of influenza in India. Statistical data are there, and the bar chart indicate that the incidents are increasing. So by these presentation, we learn that it does exist in India. Dr. Ravi, over to you. This is one study done in the Tamil Nadu. Can you highlight on these? Over to you, Dr. Ravi.
Thank you, Dr. Ketan. Thank you, Dr. Jog, for kind words in the beginning and enlightening our session. So this is a study just to highlight the incidence of the influenza, which is generally undermined and which has been growing in awareness day by day and year by year. And this is one of the effort to make it more and more uh, popular amongst the pediatrician, and its prevention by through vaccination and maybe preventing the complications through the earlier therapy. So this study was done by Department of Virology in 2019 at King's Institute of Preventive Medicine and Research. And in this study, 36,670 specimens were subjected for the influenza analysis. And this study was done over a period of 7 years. So this basically highlighted that the influenza positivity started with the onset of monsoon and peaks during the post-monsoon season. So the main crux was the year-around circadian rhythm of the influenza viral infection. And the trend was that the influenza positivity was generally there throughout the year, but there was distinct peak with the onset of monsoon. So before knowing influenza, we should know what is the influenza-like illness, which we generally day to day see in our practice. So any acute respiratory illness with a fever of more than 100.4, with cough, sore throat, and any associated symptom like body ache, headache, fatigue, myalgia, running in a stuffy nose, we categorize as ILI. And influenza is one of the most important pillars of ILI, and it is one of the most common infectious disease caused by influenza virus. The virus is highly contagious, and it is a acquired from airborne route, and that occurs in the seasonal epidemics and manifests as an acute febrile illness. It can cause very mild illness to very severe decapitating illness. Serious outcomes of the flu infection can occur, and hospitalization is also seen with influenza virus, especially amongst the young infants and elderly people. Next.
Please
So
continue.
the influenza virus has been genetically demarcated in three groups depending on the nucleoproteins. So influenza A virus, which is the most common and most severe disease-causing virus, it causes frequent epidemics due to major and minor antigenic shift and drift. And it causes periodic pandemics also because the virus may cause reassortment. Here, I would like to highlight the shift and drift in the influenza A virus. So, minor genetic mutations result into shift, and which leads to new virus every year. So, we need to protect from that virus year by year. That's why the influenza viral vaccine is inoculated every year. And there are sometimes major antigenic shift, like whole reassortment of the genome, and which is a major threat and which causes pandemic that we have seen like previously during the epidemics in Spanish flu in 2018, 1990, 19 Asian flu, then Hong Kong flu, and then we had our famous swine flu uh, in 2014. Second is influenza B virus, which in fact purely human, but it does not causes many variation in its virus. It has two lineages, but they are very stable, and it generally cause local epidemics. Influenza C virus is pretty stable virus. It infects human and swine, but it causes very mild illness, which is probably practically insignificant to our day-to-day practice. Influenza D virus is also there, but it does not cause illness in the human, and it is generally limited to cattle. So presently circulating viruses in our area is generally H1N1 and H3N2 amongst the type A virus, and few cases of influenza B virus as well. So if we talk about the transmission of the flu virus, so as we know that flu is very highly infectious disease and it is very easy to catch a flu. So people with flu can spread it to others up to 8 feet distance. And the flu virus is spread mainly by the droplets. Either the patient is sneezing or coughing, it can spread to a far distant place. These droplets can land in the mouth or noses of the people who are nearby or possible in the same room, or they are inhaling the content, the air. So people should always stay from the affected person and stay home if sick. It is also important to wash hands, that we know that universal precaution we have to take. Wash with hands and soap and water, and infected people should wear a mask. Most healthy adults can be able to infect other people beginning the first day. The first day is the most infectious day in the flu chronology, and the infectiousness can start one day before the symptom and last up to 5 to 7 days. But the first 3 days are mainly crucial. But peculiarity about children is that they can pass a flu virus for a longer period of time, maybe up to 7 days.
Okay, Dr. Ravi, thank you.
So,
Yeah,
yeah,
please, go ahead.
Dr.
Please
Ketan.
go ahead. Yeah, go ahead, dear.
So, it's very, very hard to differentiate these illnesses. Like ILI is a broader category which incorporate everything, including H1N1, SARI, COVID, and rhinovirus, as I told, RSV. So all the things they appear similar, but there are certain distinctive features which can differentiate or give some hint to us. Like all ILI's cases do not have breathlessness. They can generally mild, may or may not have respiratory distress, but most of the cases with H1N1, SARI, and COVID-19 do have breathlessness at some point of time. Then loss of taste and smell is one of the very important thing, which is we encountered in COVID-19. It can sometimes happen in other respiratory illnesses also, but COVID, it is quite distinctive. Then other systemic involvement, especially GI involvement in the form of diarrhea, is quite common in COVID. But we do see some cases of diarrhea with H1N1 as well. Then headache and myalgia, they are very common symptom in flu. They may or may not be present in SARI, but COVID also they have some kind of headache and body ache. But headache is quite eminent in influenza A virus. Over to you, Dr. Ketan.
Yeah, thank you, Dr. Ravi. This was a very brief description about influenza-like illness, the types of influenza viruses, and which is very common, the shift or the drift and shift phenomena, which Sir has very rightly described. These are the emergency warning signs of influenza in children and adult. Being a pediatrician, we were all taught in the PALS course A, B, C, D, E. Anything related to airway which is not working well, fast breathing, trouble breathing, cyanosis, then circulation if not okay, feeble pulse. These are all warning signs. But in pediatric patient, the early warning signs before the child becomes critical is severe weakness, difficulty in breathing, not able to walk, decreased urine output. Mother has to take the child in the lap to bring to the hospital. These all are warning signs. In the adult, you'll have a confusion. There are some few CNS signs because of hypoxia, severe breathing difficulty, persistent vomiting. So we need to be aware about the various presentation of influenza-like illness. Dr. Ravi, can you highlight which are the diagnostic tests besides clinical judgment? Do we have any proof to diagnose influenza illness? Over to you.
Yes. So, diagnostic tests are not necessary in each and every case of influenza. Like, as we will probably discuss, that there are three categories of illness. So, in the category 2, generally we have use of medication, and in category 3, generally when the child is very or the patient is very sick, we go for a diagnostic test. So diagnostic tests can be in the form of rapid antigen test, which is not so commonly used. The most common diagnostic test we do use is a kind of a RT-PCR. So there can be two type of RT-PCR. One is non-subtypable and one is WHO approved typable RT-PCR, which along with positivity tells about the species of the virus also. Then there can be a viral culture which is only reserved for academical purpose. And lastly, there can be one rise in antibody titer, which is also for the research purpose only. So for common use and day-to-day use, RT-PCR is the most important test we use, and it is having very high sensitivity and very high specificity.
Thank you, Dr. Ravi. Just to summarize your diagnostic test talk, only in category 2 or 3 or a high risk group, we go for the test, and the RT-PCR, which species specific, would be the best modality of treatment. Antigen antibody detections are not very much specific and sensitive to the influenza. Going to the complications of flu, Dr. Ravi, over to you. Which are the common complications of flu or severe acute respiratory infection? Over to you.
So complications can be in the form of exacerbation of the current illness that patient is suffering, like worsening of the diabetes, worsening of the respiratory issues, asthma, chronic bronchitis, chronic renal diseases, and if the person is immunocompromised, then the flu can be severe. In children, generally we have exacerbation of the respiratory illness and spread of the respiratory illness in the form of otitis media, sinusitis, bronchitis, acute respiratory distress syndrome, and secondary infections in the form of pneumonias. These are the common complications we encounter in day-to-day flu.
Now we'll go to the management of influenza. So in a clinical practice, the season, presentation, we thought of a probability of influenza illness. We thought of diagnosing it by category 2 or category 3. And once we suspected with a family history of respiratory infection, it's most likely a viral, and most likely in this season, it is an influenza disease. The antiviral therapy with oseltamivir comes into the category 2 or category 3. Category 1 is just a supportive treatment, bed rest, increased fluid consumption, cough suppressant, antipyretic such as paracetamol, or sometimes NSAID for high fever and myalgia. Most patients with influenza recover in 3 to 4 days. However, malaise may persist for weeks. Severe cases may require intravenous hydration and other supportive measures, especially in category B and C. For category B and C, we have two varieties of antiviral therapy. One is a neuraminidase inhibitor. Another group is adamantanese. Neuraminidase inhibitor, they block the viral neuraminidase enzyme, which is critical in releasing viron from the infected host cells. These drugs are active against influenza A and B, and the prototype is oseltamivir. Zenamivir is not routinely available. The most studied drug is oseltamivir. Adamantanese, they interfere with the hydrogen ion channel activity of the influenza A virus, thus blocking its entry into the host cells. It is active only against influenza A virus, while the neuraminidase or oseltamivir is active against A and B both. So the example of adamantanase is amantadine and rematadine. Looking to the pharmacodynamic and kinetics, oseltamivir remained the choice because it blocks the enzyme. Then it is active against A and B, both virus. So oseltamivir is a potent and selective inhibitor of all of the neuraminidase enzyme of the A and B. It is a prodrug which is converted to the active form in the liver. It inhibits influenza virus replication and pathogenicity, and it prevents further spread of infection. It is effective against all subtypes of A and B variants. This is the theoretical demonstration. The neuraminidase enzyme is here, and once it is blocked, there is no release of virin. and there is a replication which is totally blocked by using the oseltamivir. It was the first oral neuraminidase inhibitor and it is approved in more than 100 countries. This is the dosage regime. We all know for less than 15 kg, 60 milligram per day divided twice daily, 15 to 23 kg, 90 milligram per day divided twice, 23 to 40, it is 120 milligram per day, and more than 40 kg, it is 150 milligram per day. Or infant, less than 2 weeks, 2 weeks to less than 1 year of age, it is 3 milligram per kg twice daily. We need to remember these dosage. It is used for chemoprophylaxis also. The dosage is mentioned in the table. Dr. Ravi, over to you. We studied or we discussed out the oseltamivir, its effect, the clinical implication by this case scenario. We can highlight that oseltamivir is a very good drug. Dr. Ravi, over to you. Please describe the cases which we have faced. Over to you.
Okay, thank you. So these are the live cases we have had in the last couple of months, and they highlight the importance of detecting the influenza and simultaneously early treatment or treatment at all with antiviral drug is important or not. So coming to the first case, it was like Ishani, 6.5-year female child, resident of Vesu, Surat. She was immunized for routine childhood vaccination but had not taken influenza shot for the last 2 years. She presented with fever, which was high grade 103, 104 degree Fahrenheit, almost continuous, and just temporarily relieved by antipyretics, with cough and cold for the last 2 days, and severe throat pain for the last 1 day. And before presenting to us, she had started having breathlessness. There was no significant past history or family history. On examination, child was a well-nourished child, febrile, oral temperature 104 degree Fahrenheit, mild tachypnea with a respiratory rate of 42 per minute with mild retractions, tachycardia with heart rate of 150, BP 90 by 60 millimeters of mercury with a saturation of 93 to 94 on room air. Her throat was congested and nasal discharge was present, which was watery in nature, and chest had shown bilateral crepitations. Rest, all the systemic examination was normal. Next slide, please. So after stabilization of the child, investigations were sent with the child was having a normal hemogram with normal counts, near normal counts. CRP was 6.7. X-ray, which was done little later, showed perihilar opacities and increased bronchovascular markings. Considering above finding and the season for influenza and sick child having a respiratory distress, a respiratory multiplex PCR was sent, which had revealed H1N1 virus. Next. So child was started on IV fluid, oxygen inhalation with nasal cannula. And after after the stabilization, we started after taking the respiratory multiplex PCR. We, on suspicion of influenza, we had already started oral oseltamivir, uh, and which was like, continued after the influenza report. Child continued to have high grade fever for the next 24 hours and required paracetamol infusion. But after 24-hour fever spike started declining, respiratory distress settled around 24 hours, and child was gradually weaned off from oxygen. At 72 hours, child was afebrile with no respiratory distress, cough persisted, and it was quite troublesome cough. But the child was discharged on oral oseltamivir and decongestant, and as and when required cough suppressant. Child had a good appetite at the time of discharge. So the highlight message was this case highlights the rapid progression of the disease within 1 or 2 days. And once we diagnose it rapidly and start the antiviral therapy, there was a rapid recovery and good response in the clinical condition of the child. So case 2, so this is a 10-year-old boy, Prishit. He was a known case of seizure disorder, and the child was on oral valparin and was seizure free for the last around 1.5 year. Child presented with persistent cough for 3 days. Fever was for the 3 days around 102, 103, with severe weakness, lethargy, body ache, and complaints of heaviness of the chest. And before coming to the hospital, child had one episode of stiffness of the both upper limb and upper of the eyes, which was very transient. Child was admitted in emergency department. His weight was 33 kg, height 137. He had a temperature of 101 auxiliary, pulse rate 137 per minute, and respiratory rate of 38 per minute. He was maintaining saturation in room air with normal blood pressure without any respiratory distress. Child was fully conscious and oriented when he presented to us, and there were no abnormal movement at that time. His throat was grossly congested, and chest had bilateral conducted sound with wheezing sounds or rhonchi were present. His CNS examination and other systemic examination were essentially normal at the time of admission. So child was investigated with routine investigation with hemogram, electrolyte, calcium. These all were normal. CRP was 18.6. Then later we did an X-ray which showed bilateral parahilar prominence, and flu panel was sent in this child which was suggestive of influenza B. So this is a similar kind of X-ray which we see in flu cases in our day-to-day practice with these kind of parahilar opacities and involving both the lungs. So child was started on IV fluid, IV amoxicillin, amoxiclav and levosalbutamol nebulization, and oral fluid was added later on after the report. Child improved after around 12 hours. His nausea, lethargy, cough, they persisted for a few days, but no further seizures, no respiratory distress, and respiratory signs were continuously subsiding. And later, child was discharged on day 3 of oral oseltamivir. So this case highlights two things: that influenza B can also be responsible for some kind of a serious flu infection, and influenza complicates the underlying comorbid condition, or like it can give rise to exacerbation of the underlying condition. Moving on to case 3, she is Avdi, 14-year-old female child. She presented with fever for 6 days. So initial 2 days it was high grade. The child was traveling at that time, and they took some local antipyretic treatment or local medications there. Then fever gradually decreased in intensity. So child was having increasing cough. The main symptom was increasing cough and severe lethargy. Even at the time of admission, child was unable to stand, and child had to be brought in a wheelchair and had severe dizziness. There was family history of fever and cough in two of her family members where she had traveled in the past week. On admission, child was dull looking, febrile 101 degree Fahrenheit. Child was quite dehydrated, blood pressure of 90 by 60, respiratory rate 32. She was maintaining saturation in room air, and there was no respiratory distress at the time of admission. Her throat was grossly congested, conjunctiva were congested. Child had lot of stomatitis. The chest had shown bilateral fine crepitation on the bases, and rest of the systemic examination was not remarkable. On routine investigation, child had hemoglobin of 14.2, so which was hemo concentration as we compared it from her last investigations. Child had leukopenia with a count of 3,400, and platelet count also had fallen down. CRP was normal, and chest X-ray had shown bilateral lower zone haziness. It's kind of a interstitial pneumonia, and we sent a biofire for this child, and surprised to see influenza A virus. Child was started on IV fluid, IV ceftriaxone, and nebulization. Then he added on to oral oseltamivir. After rehydration, child shown significant improvement in her general condition. And after 36 hours of oseltamivir, child improved dramatically with improvement in fever and respiratory sign as well as in her lethargy, body ache, and general symptoms. And child was discharged after 3 days after 3 days on oral medications. This case highlights the effectiveness of oseltamivir in prolonged influenza illness also. Like generally we consider if we start oseltamivir in 1 or 2 days, it is most effective, and probably after 4 or 5 days it may not be effective. But in our case and in many cases also, we see that even if we start oseltamivir late in the course of the disease, it can have some benefit, maybe not as that much in early phase, but it is still worth giving. Over to you, Dr. Ketan.
Thank you, Dr. Ravi, for narrating the real case scenarios. And we all do agree that oseltamivir has a very important role. If started on day one, effect is very good. Maybe on second, third day, we can discharge the patient also. Just last couple of days, we had a good number of patients who were admitted with high fever, rash, cough, cold. We thought of probably dengue fever, but it was negative. Coughing occurred after second, third day, all classical features of influenza. And once we started oseltamivir, they all responded very well. And within 2 or 3 days, they were discharged. So early onset, early drug, good response. On the midway between second and third day, still you have a good response. And in the late days also, it has some role. So benefit of doubt should be given. And even in WHO recommendation, it is there. So these are the three classical case scenario. Now we'll look at the high risk category. Any infant 2 weeks old coming to you with a suspected case of influenza-like illness, there is a role of starting oseltamivir in these cases. If you have a family history positive, definitely you should start. Although a word of caution that nowadays RSV season is also going on, so beware about the RSV also. The second is a known case of nephrotic syndrome with a family history of respiratory tract infection coming to you on steroid. Definitely they need a treatment. 9 years, known case of asthma coming with you with influenza-like illness, definitely there is a role of oseltamivir. So these all are high-risk category where empirical use of oseltamivir is definitely justified. It is a wonderful drug for walking pneumonia and early onset severe symptoms. There are clinical trials which does mention that early use or empirical use of oseltamivir helps you. Early use will reduce the prolonged lower respiratory tract infection, prolonged lower respiratory tract related complications, and even the rational use of antibiotic will be justified if you have an influenza which has been diagnosed. Reducing occurrence and severity of pneumonia due to H1N1 by early oseltamivir. This was a retrospective study of 442 patients. Median time from symptom onset to administration of a drug was 5 days, and subjects were divided into these categories. Everywhere it was found out that the probability of severe pneumonia and probability of any severity of pneumonia reduces significantly if you start the oseltamivir. Same here in the graph, patients with a shorter time to oseltamivir administration were discharged earlier from the hospital. The recommended duration for post-exposure prophylaxis is 10 days. The second use of oseltamivir is post-exposure prophylaxis. Any family member having a flu disease, the prophylaxis should be given to the high-risk category. 10 days is recommended. On even in the community outbreak, up to 6 weeks it can be given, and up to 12 weeks in immunocompromised patient. So guideline recommendation would be WHO recommended that empirical treatment is strongly recommended. treatment should be started as soon as possible. Laboratory confirmation of influenza is not necessary for the initiation of treatment. Negative laboratory test does not exclude the diagnosis in all patients. If high risk individuals have been exposed to a patient with influenza, consider presumptive treatment or prophylaxis with oseltamivir. This has been supported by the Ministry of Health and Family Welfare, Government of India. Empirical treatment is recommended in all SARI patients also. In adults with community-acquired pneumonia who test positive for influenza, should the treatment regime include antiviral therapy? Yes, because the empirical antiviral does help in reducing the morbidity and mortality. So in summary, proper diagnosis can and early treatment can prevent flu complications. Empirical use of oseltamivir reduces lower respiratory tract complications, hospitalization, and antibiotic use. WHO, American Thoracic Society, and Indian government also recommend empirical use of oseltamivir. Thank you so much. Over to you, Dr. Jog sir and Dr. Prashant.
Thank you. Thank you, Dr. Ketan, for an excellent presentation of this topic along with Dr. Ravindra. And I will, of course, add some points from my side. Before that, I have only two quick, simple questions, one each. So, Ketan, for the benefit of the listeners, I will just request you to tell them as to, many times patients come with high fever, and in the periphery our colleagues do not have the facility of doing the throat swab or the nasopharyngeal swab, and many times they'll end up in prescribing some antibiotic like amoxicillin or amoxiclav in the beginning. Okay. Later on, sometimes the presentation appears as if it is like influenza, and at that time somebody says early use is really useful, which is a fact. So they also tend to start with, oseltamivir. The question is, when both these medicines are being given to a child, how rational is it? And can one be really rational in continuing only one and discontinuing other, like, in particular situations which are little tricky? So how you tackle this situation? Because, on one side, many times in our meetings and conferences, we say, we have to be rational, use either antibiotic or antiviral. But there are really some situations where one is really puzzled. So how would you look at this situation?
Yeah, thank you, sir. So the basic rationality is a viral fever which comes with upper respiratory, lower respiratory, acute onset with a high fever, and severe myalgia. These are classical symptoms of any of the viral infection. And looking to the epidemiology, if it comes into the July, August, September, January, February, March, most likely it is an influenza. There, the flu disease or a flu treatment is rationally recommended. Antibiotic can be avoided. Simple, if there is a significant running nose, it is unlikely to be a bacterial disease. So above 1 to 2 years of the age, if the patient comes with category B and C, this is recommended. Any child who comes between 2 to 4 years of the age in a present given scenario, most likely it could be a respiratory syncytial virus, RSV. But if you have an adult patient who has been affected with viral illness and child getting the disease, probably that is influenza, because RSV doesn't affect the adult. So only small kids, respiratory symptomatology, 2 to 4 months old, probably RSV, and adult affected, then probably influenza-like illness. So these way rationality can be maintained. Thank you, sir. Over to you.
Sure. So I understand that antivirals can be given depending on those situations, and maybe the percentage of secondary bacterial infections in case of influenza is about 25%. And that is why sometimes even after starting the antivirals, many of these children who remain or continue to remain sick, and in case if the counts reflect that infection is bacterial. And also, there are certain indicators of bacterial infection, then one can be rather, rational in giving both. But otherwise, as you say, depending on the onset, depending on the age, depending on the family history, and so many other factors, one can try to be as rational as possible. And particularly in the categories B and C, one is fully justified in giving antiviral agents. In case if the epidemiology suggests that the flu season is on and the presentation is like influenza. Thank you for that. And there is only one question, Dr. Ravindra, for you. In your cases, you have shown the cases coming with H3N2 and H1N1 and type B. Now, many times it so happens that in major cities like, say, Surat or Pune or Mumbai, we tend to send these throat swabs. And there are some other viruses which are also reported, like rhinovirus or sometimes, adenovirus or sometimes RSV. So when you get, these viruses, one really gets confused as to, on one side I am, facing a child who is presenting like flu, but the virus is seen, some other virus is seen. How is your approach? So, which viruses you consider to be very important and they need the therapy, and which are the ones which you can neglect? And of course, in the presentation, you mentioned that the sensitivity and the specificity of the RT-PCR is very good. What is your overall, comment about different types of coexisting viruses?
Yes, sir. So RT-PCR can be sometimes a double-edged sword, which can confuse you more than help you. And there can be bystanders in the form of some bacteria, some viruses. The great example is that if you see the RT-PCR, it does not include pneumococcus, which is a most important bacterial pathogen which causes illness. Because pneumococcus is a common commensal, and we will get in each and every kind of a report that pneumococcus is there. So it will be very confusing. So that's why from the upper airway panel they have excluded it. Similarly, in our day-to-day practice, rhinovirus is a very common bystander. It is probably seen in many cases, even bacterial as well as viral. Sometimes with mycoplasma, you have rhinovirus. So it is better to be, considered as a commensal. But one thing is for sure that if you pick up influenza, it is never a commensal. It is always pathogenic. So influenza always precedes. If whatever report is there and influenza is there, we have to take with a pinch of salt, and probably it is a true infection.
Thank you. Ketan, do you want to add anything to what he said?
No, sir, he has rightly said that looking to the clinical scenario, influenza can be commensal. Rhino, Nova, Boca virus, they can be commensal and they can be ignored. And they does not cause severe respiratory illness. So I do agree with Ravi.
Thank you very much. So these were two important questions which I thought we should address. So just to summarize whatever we have discussed and adding some inputs from my side, I will say that, of course, I will only highlight some important points which you have already mentioned. So I would say that influenza is one infection which is transmitted from a child to the adult in majority of the cases, as opposed to COVID, which is transmitted by the adults to children. And that is why immunization of children is of primary importance, so that in the family there are high risk individuals like the grandfather who is asthmatic, father who is diabetic, somebody has some other chronic illness. And that is why immunization and treatment also of children is very, very important. We witnessed in COVID that basically adults were involved and children were not the ones who were majorly involved. So in this way, influenza prevention by vaccination is extremely important. So that is one important thing. Secondly, you also mentioned about the drift. Now that we are having the program for our pediatric colleagues from Surat, so I would say the influenza virus apni Surat badalta hai. Every year, this virus will change the Surat, isn't it? And so, of course, So in Surat, Ketan can become Chetan. Okay, so both are there in Surat. I know that. So that is drift. That is annual drift. Okay, but it suddenly Ketan becomes Ravindra. That is a drift, isn't it? So that is something which we observe during pandemics, isn't it? So that drift and shift are some important concepts. You mentioned about the H and the N, that that hemagglutinin and neuraminidase. These are the two glycoproteins which are present on the virus. And hemagglutinin is basically required for attachment to the respiratory epithelium. Okay, so the virus first attaches, then it releases the RNA. See, these viruses like flu and COVID, they are very naughty viruses. Why naughty? Because they change. I told you, they change their surat. Okay, so these naughty viruses, they release the RNA inside the normal respiratory epithelial cells, then they replicate themselves, and then they want to come out and again infect the other respiratory epithelial cells. So hemagglutinin is required for attachment, and neuraminidase is there, which acts on the outer part of the respiratory epithelial cells, and then it produces the cleavage of those different influenza virus particles which have collected, and they are ready to get out of the cell to infect the other cells. So hemagglutinin of the virus and neuraminidase of the virus, both of them have different functions, and oseltamivir is a neuraminidase inhibitor. So this particular span to basically cleave those different virus particles at the exit gate, and replicating into many, that is halted by oseltamivir, and that is why other respiratory epithelial cells do not get infected, and that is how the progression of the disease is halted. So that mechanism, I thought, should be clarified. Secondly, these coexistences of two things. One is, during the monsoon, even dengue fever is going on to a great extent. And many features like headache or body ache and pain and all, they are very, very similar, and one gets confused. So one has to be very clear that on day 3, day 4, 5, we know that dengue is dangerous on day 5 and day 6. So even if you are thinking that it is influenza, be watchful, because everybody may not do the tests for these viruses. So those days where complications are very common in case of dengue, one has to be observant whether the child is getting serious on day 5 or day 6. That is one. And as Ketan mentioned about coexistence of RSV like viruses, it is also important because that may complicate the child. So on one side you are treating with the help of oseltamivir, but the child is not improving. So what is the problem? So it could be either some bacterium, which I said in 25% cases could be there, or there could be coexisting other virus, which has probably led to equal problems. So that is also one important point. I am glad that you mentioned about the categories, because for category A, where symptoms are very mild, we are not going to investigate, neither we are going to treat. Okay, that is why one has to remember. One important thing is that complications of influenza are also to be remembered. I always say influenza A is associated with all the complications starting from alphabet A, like ARI, that is pneumonia, ARDS, that is acute respiratory distress syndrome, AOM, that is acute otitis media, then asthma exacerbation, then absenteeism from the schools, okay, and also antibiotic abuse. Okay, so all these are associated with influenza A, and this is very important. So prevention of influenza is important so that these complications are also prevented. So all in all, I think this virus is a, what you say, Fast and Furious. I remember one movie where some Chinese actors were there, Fast and Furious. Okay, so this virus is like Fast and Furious. The virus produces acute symptoms, sudden onset of high fever, then rapid progression. Even oseltamivir has to be given rapidly, otherwise the child will get a vertical discharge. And so most of those important points are very rapid in relation to this particular virus. So we need to remember that if you want to give, you have full scope of giving empiric therapy. So this is one, place, surprisingly, we always say don't give empirically, don't give empirically. But here is one condition where you can use. Even WHO has said that if the other things are, supportive, like epidemiology, history of contact, rapid progression, category B, C, then you are fully justified in giving oseltamivir. And as Ketan and Ravindra, both of them mentioned, even if you give it little late in the course of illness, it does have the utility. So you did not worry now that only 48 hours, not that it is so, you can give it even little late. Okay. So I think most of these important points have been covered. So I thank Ketan. So I would say Ketan is for imparting knowledge to the audience, and Ravindra R for elaborating rational approach to the flu patients, and resulting in Muskan. I think the name of the hospital, your hospital is
Yes.
Muskan. So giving Muskan on the faces of the child. So very important thing. Both of you have given an excellent information with the help of cases, and I thank both of you, and also Hetero for giving me the opportunity to moderate the session and having an excellent discussion for the benefit of our listeners. Thank you.
And
Sir,
adding
thank you very
Pramod,
much.
Dr. Prashant,
I must say, every time I learn something from you, today's session, I can never forget the difference between shift and drift. Very beautiful
Pramod,
addresses.
I would
Always
like to add one line. We are
Yes, sir.
thankful to Dr. Pramod Jog sir for adding Pramod into the lecture.
Lovely.
Thank you.
That was
Thank you.
beautiful.
Thank you. Thank you. Thank you.
So thanks all of you for this wonderful session. Thanks, sir. Thanks, Dr. Ketan. Thanks, Dr. Ravindra. Nice meeting you all again.
Sure.
Thanks all the audience who took time from the schedule and came. Thank you, marketing team, Hitro, and IT team and field personnel. Thank you so much. Signing off and wish you a very pleasant evening. Thank you, sir, once again.
Thank you. Thank you, Pramod sir, Dr. Ravi,
Thank you.
Dr. Prashant. Thank you.
Thank you, sir. Thank you,
See you
Dr. Ketan.
soon. Thank you.
Thank you. Bye.